Evidence suggests that many of the side effects of valproate, including thrombocytopenia, elevated liver enzymes, elevated serum ammonia, and alopecia, are dose-dependent. Weight gain is also a common side effect of valproate, but is the amount of weight gain also dependent on dose? Would a smaller dose of valproate minimize weight gain, along with other metabolic risk factors? Hi, Paul Zarkowski here with the Psychopharmacology Institute. Luckily, a new study was published recently in the Journal of Clinical Psychiatry to answer this question. The study sample included 215 patients who were starting valproate with subsequent follow-up for up to a year. The sample was split evenly between males and females. This even distribution is of note considering caution among clinicians due to the increased risk of congenital disabilities during pregnancy. A mentor once told me that the best way to approach any data set is with a simple scatter plot. In this case, if the dose was on the x-axis and the weight gain was on the y-axis, you would see an apparently random collection of dots, each representing one of the 215 subjects. In this rectangular collection, you would see some subjects on the largest doses of 2,000 milligrams a day that lose 10% of body weight, and patients that gain 15 to 20% of body weight on the smallest doses of 500 milligrams and less. It is easy to miss the statistically significant positive correlation of 0.13 between weight gain and dose of valproate. To make this more useful in advising our patients, the authors implemented a linear mixed effect model to control for sex, age, baseline body mass index, smoking status, diagnosis of schizoaffective disorder and schizophrenia, and other concurrent medications known to cause weight gain, including antipsychotic medication. Only 3 of these factors were significant. Baseline body mass index was negatively correlated with weight gain, as the subjects with lower BMI gained a greater percentage of weight. Female sex was positively correlated with weight gain. And finally, the co-prescription of other medications known to cause weight gain was also positively correlated with weight gain. After controlling for these factors, the authors found that each additional month of valproate is associated with a statistically significant weight gain of 0.16% of body weight. That would be almost 2% weight gain after a year. The authors also found a significant correlation with dose, with weight gain of 0.5% for each 500 milligrams of valproate over the course of treatment. To summarize, a patient taking 1,500 milligrams of valproate for a year could expect a 3.5% increase in body weight. For the typical 70-kilogram subject, this would be 2.5 kilograms. Or, for us Americans, about 5 pounds for a patient weighing 155 pounds. The primary clinical value of this finding is the suggestion that part of the weight gain associated with valproate could be avoided by prescribing the lowest effective dose. The authors cite a starting dose of 20 milligrams per kilogram per day for patients with bipolar disorder, or 1,400 milligrams of valproate for a patient weighing 70 kilograms. In my informal survey of practicing clinicians, patients were started on smaller daily doses, typically 500 milligrams, possibly in divided doses, with adjustments based on valproic acid level and clinical response. This study highlights the benefit of the starting low and going slow model, in which it may be possible to find the lowest effective dose to reduce weight gain. In addition, the authors noticed that weight gain was not evenly distributed over the course of the first year, but occurred primarily in the first 3 months. By implementing a piecewise model, the authors found the weight gain to be over 4 times greater in the first 3 months, at 0.56% of body weight per month, than later in the course. This finding highlights the need for attention to weight at the start of a course of valproate. No associations were found between valproate dose and other metabolic markers, including blood glucose, lipid levels, or blood pressure over 6 months. But one could wonder if 6 months is long enough to detect these effects with moderate weight gain. This study has a few limitations, including that the dose was not random, but based on clinical factors. It is very difficult to control for every possible clinical factor that could account for weight gain, independent of the dose of valproate. Nevertheless, my take-home point is a suggestion of less risk of weight gain and subsequent metabolic risk factors with smaller doses of valproate. This highlights the benefit of determining the lowest effective dose to avoid weight gain, but also other adverse effects.